لا هاي بتشغل.
We all know it's yellow discoloration of skin and sclera and mucous membranes due to increased concentration of bilirubin above normal level, either direct or indirect bilirubin. And it's a very important step when we examine, for example, the GI system to comment on the presence of jaundice or the absence of jaundice. So you have to mention it as a pertinent negative or even a pertinent positive in physical exam, especially in specific situations or when you think about specific differential diagnosis on your list. Usually, jaundice is apparent when bilirubin level is above 5 milligrams per deciliter. So below 5 milligrams, you can't actually tell whether the patient is jaundice. And you might even need a higher level, more than 5, in kids with dark skin. Dark skin kids, it's very difficult to tell whether they're jaundice at a 5 milligram per deciliter. So sometimes it can be challenging to evaluate. It's a very common problem, okay? Most of full-term babies, more than half of them, about 60 of them will at one point after birth develop jaundice, and percentage is much more in preterm, so more than 80% of preterms can develop jaundice, which, as I said, bilirubin level of more than 5 milligrams per deciliter, specifically in the first week of life. Now, the level that I worry about in term babies somehow are slightly different from the levels that I worry about in preterm babies. Some of preterm babies, like the minority of jaundice term babies, 8 to 9%, develop a higher concentration of bilirubin of more than 15 milligrams per deciliter in the first 7 days of life. Why do we take care of jaundice? Why do we need to diagnose and manage jaundice as soon as possible? Because of the risk of its complications. Most important complication is kernicterus. And this happens when bilirubin concentration, indirect bilirubin, reaches above or equals to 25 milligrams per deciliter, which can lead to permanent neurological sequelae, okay? So that's why we need to identify jaundice as early as possible and manage it accordingly. So how bilirubin is metabolized in our body? So we know that it all starts in the RBC. So there's a heme ring, right? So when the RBC is hemolyzed or destructed, this heme by heme oxygenase will be converted into biliverdin, and by biliverdin reductase, this will form into unconjugated or unbound bilirubin or indirect bilirubin. And then there is an enzyme in the liver produced by mature hepatocytes. We call it UDPGT, which is decylated-defined phosphoglucoronate transferase, which is the conjugation enzyme. This enzyme turns unconjugated or indirect bilirubin into conjugated bilirubin. Conjugated means water soluble, so the indirect is lipid soluble, and the direct conjugated is water soluble. So this is a very important step, because in order for our body to deal with bilirubin through the intestines to be excreted by stool or urine, it has to be water soluble, right? Because the environment in our intestines and urine is water based. So it has to be water soluble. That's the main step of the conjugation, is when UDPGT turns indirect or unconjugated into the direct form or the conjugated bilirubin, and then in the intestine, because of the presence of the intestinal microflora or normal flora, this will be turned to urobilinogen, and this urobilinogen will be excreted in urine, given the urine its color, and some of it will be reabsorbed, go back again to the biliary system and to the liver to start the circulation all over again. And the majority of urobilinogen will be turned into stercobilinogen, which will be excreted in stool, given stool its brownish color. Okay. So the difference between conjugated bound or unconjugated bilirubin. So conjugated, as I said, it's water soluble. Unconjugated is lipid soluble. So because it's lipid soluble, it can cross our blood-brain barrier. That's why it's CNS toxic. That's why indirect, unconjugated, lipid-soluble bilirubin implies a risk of kernicterus. need to manage indirect hyperbilirubinemia as soon as possible. Conjugated form, it's water soluble, non-neurotoxic, so because it can't actually cross the blood-brain barrier, can cause central nervous system problems. However, literature says in high levels it can be toxic later. Now, if we have a pathological condition where there's a very large amount of bilirubin being produced, so the UDP-GT enzyme can be overloaded. So not all the bilirubin will be conjugated. So a form of it, even if we don't have a problem with our enzyme, will be unconjugated. Thus, this can be toxic to our CNS system. So this is what I mean when I say toxic in high levels to the brain. How do we classify jaundice as a presentation or as a clinical sign? We define it and we classify it into either physiological or pathological jaundice, unconjugated versus conjugated, and we rely solely on sometimes on the onset to tell whether this is physiological or pathological, as a hint in our history taken. Physiological jaundice means there is a physiological process, there is no underlying pathology. To say that this kid or newborn has a physiological jaundice, it's a diagnosis of exclusion. So I have to exclude the most common causes of jaundice in newborns to finally say this is physiological jaundice. And by that, I mean I need to run investigations to rule out hemolysis, lipidic percentage of red count, hemoglobin level, etc. So why does physiological jaundice happen? So when newborns, when they're first born, their red blood cells lifespan is very short. So the turnover of RBCs is very quick. So within 70 to 90 days, RBCs will undergo hemolysis. While later on, after the neonatal period, the RBC lifespan will increase up to 120 days. The second cause is that when we're first born, the RBC mass is increased. We have a large RBC mass, so more heme and more bilirubin production. Immature ligandin, and ligandin is the bilirubin binding protein. So immature ligandin means bilirubin molecules will remain unbound or free in the circulation. Less UDP-GT enzyme, which is, as I say, the enzyme responsible of conjugating bilirubin. High activity of beta-glucuronidase enzyme in our gut, in the neonate's gut when they're first born. And this will inhibit the conjugation of bilirubin, and I will explain that it also sometimes can be present in some women's breast milk. Decreased flora in the gut, and as I say, because there's immaturity in the liver, immaturity in the metabolic hepatic pathway sometimes, this will lead to inefficient conjugation of bilirubin and resulting in accumulation of bilirubin and hyperbilirubinemia and jaundice. So, in term infants, they will reach a peak at which they have the highest concentration of bilirubin, in case we're talking about physiological, which is almost about day number 3 of life. And this physiological hyperbilirubinemia does not usually exceed the level of 12 milligrams per deciliter. However, in premature baby, this peak can be more delayed, so it happens at day 5 of life, but it's more exaggerated, so they can reach a limit of 15 milligram per deciliter. Usually physiological jaundice will disappear gradually, so it's most of the times it's undetectable beyond 2 weeks of life, unless in specific exceptions, like in breast milk jaundice, it can be delayed. You can still see breast milk jaundice at an age of 2 months, for example, of age. So pathological jaundice, so when there's an underlying pathology leading to the accumulation of bilirubin in our bodies. So when do we suspect pathological jaundice? So if we have a bilirubin level increment of more than 0.5 milligram per deciliter per hour, and it's very hard to do hourly monitoring, so we don't do that, and we don't usually rely on this parameter. If the peak bilirubin in a term infant, so in a term infant's peak, they rarely reach above a level of 12 milligram per deciliter. So if it exceeds 30 milligram per deciliter in terms, or if the portion of the direct bilirubin out of the total bilirubin is more than 1.5 milligram per usually pathological. So if we have a total bilirubin level and then I calculate the direct, I divide the direct over the total. If it's more than 20% as a rough estimation, or more than 1.5 milligram per deciliter, this is considered pathological jaundice. I always should suspect pathological jaundice if the baby has any other positive clinical signs like hepatosplenomegaly, or if the baby is anemic or undergoes hemolysis. Sorry بس لازم ارجع التليفون.
مش مشكلة، خذي راحتك.
So this table provides you with more details and differences between physiological and pathological jaundice, the onset, rate of bilirubin rise, serum direct bilirubin level, and the duration of persistence, and how they clinically present. So you need to refer to this table. It's a source of exam questions. Okay. Pathological jaundice. Why does pathological jaundice happen? What's the underlying pathologies that will lead to jaundice? So either we have increased production of bilirubin, and this increased production is either due to hemolysis, so more RBCs are being destructed, as in the case of ABO incompatibility or RH incompatibility between the fetus and the mom. If the baby is born with, again, I'm talking about newborns. If the baby is born with polycythemia vera or increased RBC mass, this will lead to also increased risk of pathological jaundice. Or if the baby has enclosed hemorrhage. Remember when I explained the physical exam lecture, we said we fear hepatohematomas, large ones, because the blood collected hematomas can undergo lysis, hemolysis, and cause the formation of jaundice. The second mechanism or pathology to how hyperbilirubinemia happens that there's decreased clearance, so there's regular production of bilirubin, so there's no problem with increased production, but our body is suffering or can't excrete or clear this bilirubin out. This happens in sepsis. In sepsis, patients or newborns can have biliary stasis, significant biliary stasis. If the patient or the baby has perinatal asphyxia or hypoxia, so this will also affect the hepatocyte ability to conjugate and clear out bilirubin, hypothyroidism, and Crigler-Najjar syndrome as a genetic cause. Or there is a problem with the enterohepatic circulation. So increased enterohepatic circulation means there's more time, the bilirubin is spending more time in the intestines, so there's a chance that more bilirubin will be absorbed back to the circulation, and this will lead to jaundice as well, or if the baby has gastrointestinal obstruction of any sort. Other obstructive causes, and we mean biliary obstructive causes, like in case of biliary atresia. So biliary atresia is a very common cause of direct hyperbilirubinemia. So any newborn baby with direct hyperbilirubinemia, we need to rule out biliary atresia as a cause. Choledochal cyst, sepsis, congenital infections, torch infections is a very common cause of direct hyperbilirubinemia, and this is a very common exam question as well. If there's an abnormal structure in the RBCs like spherocytosis or pyknocytes, where the RBCs have irregular borders. So we know that reticularly, one of the functions of our reticular endothelial system, like in the spleen, is to recognize abnormal RBCs, abnormal morphology of the RBCs. So if they pass through the reticular endothelial system and they are recognized as abnormal, they will undergo hemolysis even if they are still, their lifespan is within, they did not reach the maximum lifespan. They will be destructed due to their abnormal shape. And this will lead to jaundice as well. Sometimes some medication will cause deconjugation, like sulfonamides and vitamin K. So if a baby is on sulfonamide medication for any reason, the bound bilirubin molecule to albumin will be displaced. So bilirubin will go back to being unbound or free bilirubin. Thyroxine deficiency, why? Because thyroxine will increase the activity of glucoronidase transferase, and we know that glucoronidase transferase will promote the conjugation of bilirubin. That's why thyroxine deficiency causes jaundice, and galactosemia as a common metabolic disorder causing jaundice. So if we talk about indirect hyperbilirubinemia, so unconjugated, the common causalities would be hemolytic diseases like ABO/RH incompatibility, or non-hemolytic, genetic, like for example Crigler-Najjar, where there's a mutation in the glucuron transferase enzyme. Physiological jaundice is a non-hemolytic cause of unconjugated bilirubin and breast milk jaundice. So ABO incompatibility as a pathology leading to hemolysis of RBCs. So ABO incompatibility happens when the mom's blood group is O. So the mom doesn't have either the A or the B antigen, right? And the baby is A or B, so the baby carries one of those antigens. So they are incompatible. What happens is that during pregnancy there will be fetal maternal hemorrhage, means leak of small amounts of blood from the fetal circulation to maternal circulation, okay? The amount during pregnancy is not very high, but this amount can be really significant during delivery. However, so ABO incompatibility, so when this RBC, for example, when there's fetal maternal hemorrhage leaks to the maternal circulation, the mom's circulation will recognize the RBC's antigen as a foreign body, right? Because it's non-compatible. So mom will start to form antibodies against the fetal RBCs. Antibodies means IgG. IgG can cross the placenta, so they will cross the placenta to the fetal circulation, causing destruction of the fetal RBCs. And sometimes the destruction can be very significant to the point that it affects the baby in utero, and the baby can have significant anemia, hydrops fetalis, and other fatal complications as well. With diagnosis, we will have to have a high index of suspicion if the baby has indirect hyperbilirubinemia. The hemolysis indices are elevated by the leptin count, and the Coombs test, direct Coombs test is positive, okay? Now, ABO incompatibility can happen during first pregnancy. So if the mom is first pregnant, the baby can have hemolysis. The first baby can have hemolysis. Why? Because most of us have been already exposed to either A or B antigen expressed on bacteria, for example, okay? So mom's body has already formed anti-A or anti-B antibodies. So that's why it happens during the first pregnancy. Now we'll move to the RH incompatibility. So it happens when the mom has a negative RH group. The mom is RH negative and the baby is RH positive. So any fetal maternal hemorrhage will lead to leak of RBCs from fetal circulation to maternal circulation. This RBC will be recognized by mom's body as a foreign body, forming antibodies and hemolysis. However, this doesn't happen during first pregnancy. So the mom will get exposed to those RH positive RBCs during first pregnancy, okay? But the antibody formation will take time because it happens later, or it happens usually during delivery. Because as I said, the fetal maternal hemorrhage and during pregnancy is this much, so the amount of blood is very small and it's not enough to cause formation of significant antibody of significant concentration. But during delivery, the fetal maternal hemorrhage is considered significant and sufficient for the mom's body to form a good load of antibodies. That's why the second pregnancy will be affected because of the pre-formed antibodies during first pregnancy and delivery. Okay? Usually the severity of RH incompatibility is much higher than the ABO incompatibility. The immune reaction to it is much more potent and strong, and the load of antibodies formed is much more predominant than an ABO incompatibility. That's why we fear RH incompatibility. So for any mom during her prenatal visits, if the mom shows RH negative blood group, even without knowing the blood group of the baby, upcoming baby, the mom should receive anti-D medication. Okay? This will neutralize any antibodies formed during pregnancy and thus protecting the next baby from any hemolysis. Okay? Usually, as I said, babies with RH incompatibility, they present with significant anemia and they need early blood exchange transfusion to take the antibodies out of their circulation. Yeah. So usually with ABO, it's not that severe. Okay, so we usually follow the hemoglobin. If the hemoglobin level drops, we might give blood for at a certain level, for example, because I say the number of circulating antibody in ABO is not significant as in RH. However, if the hemoglobin drop is significant and if the baby is deeply jaundiced, we might give IVIG, intravenous immunoglobulin, to bound the binding sites of the antibodies formed from mom in the fetal circulation to stop them from hemolyzing the RBCs. Okay, but usually most ABO kids, they don't need this. Okay, because it's much less severe than in RH incompatibility. Other cause of indirect hyperbilirubinemia, which is a cause of hemolysis, is G6PD deficiency. What is G6PD? So it's glucose 6-phosphate dehydrogenase enzyme. This enzyme is very important in our body. It maintains normal levels of NADPH. Okay, NADPH is very important to maintain in turn the glutathione level in our body. Glutathione in our body is a very important antioxidant. So this will help the RBCs that are going under stress, oxidant stress like an infection, to overcome this stress and to prevent those RBCs from hemolyzing. Okay? And patients who have deficient G6PD, they can't maintain normal levels of NADPH. As a result, they can't maintain normal level of glutathione. As a result, any stressful condition, infection, febrile illness, medication, sometimes smells, sometimes ingestion of fava beans, they will undergo oxidant stress and hemolysis. This disorder is an X-linked disorder, so most commonly happening in males, unless there is like lionization of the X chromosome, it can happen in females. However, male G6PD deficiency is much more severe than female G6PD deficiency. It's the most common enzyme defect in the whole world. Those babies, they present with acute attacks or crises of hemolysis, leading to rapid drop in their hemoglobin. Sometimes they present with shock-like symptoms or presentation, and severe deep jaundice as well. Okay, how we diagnose? We measure G6PD level, the enzyme level. Okay, but we should not do the measurement during a crisis. Why? Because in a crisis, the RBC will be hemolyzed or destructed, and intracellular G6PD will be released out. So what we'll measure? We will measure the level of G6PD in destructed cells, but this will not reflect the baseline level of G6PD. So we wait for the crisis to subside and then we measure the level. And of course, we need to prevent any oxidant stress that might expose those kids to G6PD crisis. Like we say don't eat fava beans, for example. There are specific medications that can induce hemolysis, like sulfonamide, like anti-malarial drugs. They should not receive those medications. We give them a list of medications to avoid. Sometimes there's some studies or some talks about henna that can induce hemolysis in patients with G6PD deficiency. Crigler-Najjar syndrome is a somehow rare autosomal recessive disorder, and it's of two types, type 1 and type 2. Type 1 does not respond to phenobarbital, and they present with persistent, significant indirect hyperbilirubinemia, leading to carditis. This is a very common cause of carditis in kids. So any kid with high hyperbilirubinemia exceeding 20 or 25 milligram, they need to undergo genetic testing to rule out Crigler-Najjar syndrome. Type 2 responds well to phenobarb, and usually the levels of hyperbilirubinemia is less significant than type 1. So they have permanent deficiency in the enzyme responsible for conjugation. So they present with indirect or unconjugated hyperbilirubinemia. Gilbert syndrome, there is a mutation in the promoter region of gluconeotransferase. This will lead to mild indirect hyperbilirubinemia. Usually they are undiagnosed or underneath. Don't press it to you because the amount of hemolysis or the hyperbilirubinemia is insignificant. However, sometimes if they have an additional illness to cause hemolysis, for example, another contributing factor, they might present with significant crisis or hemolysis. Okay, a very common or one of the most common causes for indirect hyperbilirubinemia is breastfeeding jaundice. Usually this is faced in primary gravida male females, so females who are given birth for the first time. They don't have sufficient expertise on how to breastfeed their kids. They have a problem with their latching, kids latching to the nipple. They have a problem with the frequency of breastfeeding and sometimes the amount of milk coming out. So this will lead to prolonged enterohepatic circulation and as a result indirect hyperbilirubinemia. Usually breastfeeding jaundice, which is different from breast milk, appear in the first week of life, the peak between day 3 and day 4 of life, and it's very common in about 13% of breastfed infants. How do we manage? We encourage more feeding. So we tell moms to feed their kids more frequently. Okay? Breast milk jaundice is a different story. It's estimated about 2% of breastfed infants, and the onset of breast milk is more delayed than breastfeeding. So on a breastfeeding peak, day 3, day 4 breast milk, day 7, sometimes beyond day 7 of life, and the maximum concentration will be reached between week number 2 and week number 3, and it can be still seen beyond 6 and 8 weeks breast milk jaundice. It's because in breast milk there is may contain an enzyme. This enzyme will inhibit the conjugation of bilirubin, or sometimes in some studies this enzyme can lead to more prolonged intrahepatic circulation. Treatment, old schools like practice would say stop breastfeeding and go to formula milk. And I'm myself and so many other clinical centers in the world are against this practice. It's an old practice. There is nothing more precious than breast milk. So we ask the mom to continue breastfeeding its baby even though he is jaundiced. For me, putting my baby under phototherapy is fine, but depriving my baby from immunoglobulins and the benefit of breast milk, which is called in the developed country liquid gold, is for me is much more catastrophic. Okay, so continue breastfeeding even though the baby is jaundiced. Breast milk jaundice can rarely increase bilirubin to high levels in direct hyperbilirubinemia causes. We divide the pathologies into hepatic or post-hepatic. So we don't see pre-hepatic causes of direct hyperbilirubinemia. Okay, the pre-hepatic cause indirect. Direct is always either hepatic or post-hepatic. Hepatic causes like hepatitis, idiopathic neonatal hepatitis, torch infection, sepsis, inborn irritability like galactosemia and tyrosinemia. Post-hepatic like biliary atresia or choledochal cyst. I'm not going to go into details about biliary atresia. You can read the details yourself about diagnosis, management plan. Same for choledochal cyst. Okay, how do we classify neonatal jaundice according to onset? So early, intermediate, and late or prolonged. Early, we usually suspect hemolytic problems like ABO or Rh incompatibility or G6PD. Intermediate, physiological jaundice, breast milk jaundice, for example, sometimes sepsis, congenital polycythemia, etc. Late or prolonged usually are caused by hepatic or post-hepatic like biliary atresia. Okay, jaundice in children. As I said, it's a very important clinical sign to elicit during physical examination, specifically when we suspect chronic liver diseases. Again, unconjugated or indirect is either hemolytic or non-hemolytic. Hemolytic anemia will lead usually to mild to moderate jaundice. There's no abdominal pain, for example. Usually they have splenomegaly due to massive hemolysis, either with or without hepatomegaly. They will have their stool color is yellow and urine is variable in color. There There's positive family history of pathological disease or pathologies. Usually the reticulocyte count is positive, so there's evidence of hemolysis going on. Again, so we define if it's hemolytic or non-hemolytic. We need to do a Coombs test to know, okay, which differential should I think of. If Coombs test is positive, I'll think of an autoimmune or immune problem, like circulating antibodies as in Rh incompatibility or ABO or sometimes SLE or drug-induced. If the result of negative, so direct Coombs negative, I would think of enzymatic defect or enzymatic deficiency like G6PD, sickle cell, for example, or abnormal RBC shape like spherocytosis. Non-hemolytic, again, causes as a newborn or neonates, Gilbert, Higgs-Najjar, hypothyroidism, internal hemorrhage. Be aware that hypothyroidism causes indirect and direct. So it's listed as a cause of both direct and indirect hyperbilirubinemia. So conjugated is either hepatic or hepatocellular or post-hepatic, or as it's called cholestatic jaundice. I'm not going to go through details, you can just review the clinical signs and symptoms yourself. So hepatocellular jaundice, like what we see in infectious hepatitis, either viral hepatitis A, B, C, D, E, or non-hepatoviral viruses like enterovirus, CMV, EBV, etc. Some bacterial can cause hepatic insult or hepatocellular injury like typhoid, fever, brucellosis, TB, E. coli, etc. Protozoal like malaria. Drugs that can cause jaundice include salicylate or aspirin, iron, halothane, valproic acid, phenytoin, estradiol, and methyl-dopa. They all cause direct hyperbilirubinemia. Metabolic causes like Wilson disease, galactosemia, thalassemia, etc. Okay, we mentioned this. Okay. How do we approach neonates and children with jaundice? So clinical presentation, we look for hints in history, like the presence of yellow coloration, how significant or how profound it is. Is it just a face, or does it go down to trunk or lower extremities? This will indicate the severity of jaundice. The presence of fever indicating an underlying infectious pathology like hepatitis, for example. The presence of vomiting. Babies or neonates who are unable to suck or weak sucking, which might be a sign of sepsis, for example, or metabolic syndrome. Features of failure to thrive, which what we see sometimes in metabolic syndromes or chronic liver disease, abdominal distension or passage of pale stool, which indicates post-hepatic or cholestatic obstruction like in biliary atresia and choledochal cyst. So in a neonate, what do we ask? We ask about birth date, because we need to estimate, we need to know the age, okay? And now we say that we classify according to the onset, early, intermediate, and delayed. The duration and the progress is very important. The color of urine or stool, so clay-colored stool or colors, I would right away think of biliary obstruction like biliary atresia, the presence of vomiting, feeding history, weightless, maternal history, so the bottom visit of the mom. Is she Rh negative? Did she receive medication during pregnancy or not? She received any other medications during pregnancy, like NSAIDs or drugs like sulfa drugs that can induce conjugation of bilirubin, any hemolytic disease in mom's family or father's family, any significant family history, any history of premature rupture of membrane or sepsis during or after, just after delivery. In children, so older age group, again, I will ask about fever. I need to analyze the fever. Is it with chills or rigor, for example? So if it's high-grade fever with chills and rigor with abdominal pain, abdominal distension, I will suspect cholangitis. Any history of any drug history is very significant. Abdominal pain is very important to rule out hepatitis, cholangitis, cholecystitis, or liver abscesses. I need to ask about anorexia, fatigability, pallor to indicate hemolysis, any previous blood transfusion, for example, to indicate antibodies following blood transfusion, any bleeding tendency to indicate coagulopathy secondary, for example, to chronic liver disease, any rash, arthritis, and any similar conditions either in school, like outbreaks of hepatitis in school, malaria in school, for example, or in the community. Poor weight gain, recurrent vomiting, abnormal odor, this indicates chronic liver disease, developmental delay, seizure, poor vision, abnormal behavior, all can indicate hepatic toxicity and hepatic, sometimes fulminant hepatitis. How do we approach them? So again, history and physical exam are the mainstay of your management. So more than 70% of your management plan will emerge from proper history and physical examination. So we need to ask about all the features that I've just mentioned. And at examination, I need to plot the growth parameters on the growth chart. I need to make sure that the vital signs are stable, that the hydration state, specifically if the patient is vomiting. I need to measure the body temperature, to check for hepatosplenomegaly, any evidence of traumas, any evidence of injuries, easy bruisability, bruises of multiple or different ages, for example, and any evidence of connectors. How do I clinically assess the severity of jaundice? There's a Cramer's index, we call it. This indicates or give me a hint during physical examination of how bad or how severe jaundice is. So for example, if only the face is jaundice, I'm talking about 46 milligram per deciliter level of bilirubin. If it's reaching the upper trunk, up to the upper trunk, it's between 8 and 10, for example. If it's reaching the lower abdomen, reaching the thigh, it's between 12 and 14. If it's reaching the lower legs or the lower extremities and the forearms, it can be up to 18. And if it's covering the palms and soles, this is severe. So it's between 15 and 20 milligram per deciliter, and the kid is at risk of connectors if it's indirect hyperbilirubinemia. Again, physical exam need to comment on any abnormal smells like fetal hepaticus, CNS examination, any depressed level of consciousness, any seizure, any abnormal movement, tremor, for example, any abnormal neurological signs like either fine or coarse tremors. What investigations for conjugated bilirubin should I ask for? Liver function test, coagulation profile, abdominal ultrasound to visualize the gallbladder to make sure the patient has got a high index or suspicion of biliary atresia or not. Hide scan if I suspect biliary atresia, thyroid function test, metabolic screen, because as I say, some metabolic disorders like tyrosinemia, galactosemia can cause diet hyperbilirubinemia. Sometimes you will need liver biopsy. For unconjugated bilirubin, so you have to know the total unconjugated to know whether this is an unconjugated hyperbilirubinemia. CBC with differential blood film, blood group, maternal blood group, diet, homeostasis, critic count. This is the approach or the common causes for direct and indirect. How do we treat? So in unconjugated indirect hyperbilirubinemia, we need to ensure the hydration state is optimal, and the mainstay would be phototherapy. So phototherapy, the idea behind it, that it forms, so we give light under a specific wavelength. This light at this specific wavelength will convert the unconjugated bilirubin or the indirect bilirubin, the water insoluble, into water-soluble isomers, photoisomers, so that our body can deal with it and can excrete it. And if the baby has got poor response to phototherapy, or if the baby is showing signs of connectors, if the bilirubin level is very high, exceeding 20, we need to do exchange transfusion. For conjugate hyperbilirubinemia, we have to ensure adequate nutrition, and we have to treat the underlying problem. So if it's, for example, biliary atresia, the baby must go Kasai procedure, where they connect the biliary duct with the intestines to make sure that the bilirubin is being drained out. This is how babies are placed under phototherapy, so that the wavelength range is between 420 and 470. So as you can see, babies' eyes should be covered, and the testicles should be covered as well. Phototherapy can cause retinal damage and sometimes testicular damage, so we need to cover both areas. Sometimes babies might develop rash, dermatitis-like rash, or can form what we call brown baby syndrome, so brownish discoloration of their skin secondary to prolonged exposure to phototherapy. So these are the curves we refer to when we want to evaluate a baby with hyperbilirubinemia. So the x-axis is the age of the baby, and the y-axis is the level of the bilirubin. Okay? So as you can see, there are three curves. One like straight line, a complete line, and we have dotted lines. Okay? These are the risk factors of the baby. Okay? So if the baby, for example, has a low risk, okay, so the baby is more than 38 weeks of gestation, the baby has no evidence of hemolysis, the baby has no evidence of sepsis, so this is a low risk baby. So the threshold at which I start the baby on phototherapy is higher. Can you see it? It's the curve on top, the most top curve, هذا الكيرف. آخر واحد اللي فوق. Okay? So this, I have a very high threshold to start the baby on phototherapy. However, for the same baby, or for another baby of the same age, if the baby has a risk factor, one risk factor, for example, less than 38 weeks of gestation, I have a lower threshold to start on phototherapy, and I have a very low threshold to start the baby on phototherapy if the baby has more than one risk factor. So born at less than 38 weeks of gestation, plus sepsis, plus hemolysis, etc. This is belly blanket, which is a blanket that provides the baby with wavelength similar to what we provide or what's provided with the regular phototherapy. It's not available in our country, but it can be beneficial, specifically if we want to discharge the baby home to be treated. Okay, this is how we do exchange transfusion. So we'll need to have a central line, central axis. So this is an umbilical venous central line. It has like a connector with in and out. يعني line axis داخل axis طالع. فباللي طالع we draw the baby's blood and we give the baby a blood from another donor to exchange the baby's own blood. لأنه البيبي's blood فيه إيش؟ ليش نعمل exchange transfusion؟ ممكن البيبي عنده autoimmune صح hemolysis وعنده antibodies in circulation. So we replace his blood اللي فيه antibodies مع donor blood, for example, صح? And we take out in this process bilirubin in his blood. Okay, so one of the modalities of treating babies, specifically with autoimmune-related hemolysis, is to give IVIG. Home remedies for drugs are ineffective and we shouldn't try them. Okay, like put a chain of garlic, give them water and sugar, for example. Put them under the sunlight, they are mixed. We should not use them. Sunlight can cause severe dehydration, for example, for the baby. Water and sugar can cause hyperglycemia, electrolyte imbalance, sometimes significant insults. Garlic, it's a total myth, it's not beneficial, and there's no evidence in any oral medications to help. Treatment of child with jaundice depends on underlying cause, so we need to check the cause and then treat accordingly, okay? For example, if it's hepatitis, is there a treatment? Is there an antiviral medication that can be given or not? If it's, for example, CMV hepatitis, I can give anti-CMV medication, for example. As I said, connectors is a very fatal complication of hyperbilirubinemia. It happens when bilirubin level exceeds 20 to 25 milligram per deciliter, mainly due to indirect hyperbilirubinemia, which is toxic and cross the blood-brain barrier, and cause significant deposition on the basal ganglia and the brainstem nuclei, as I said, leading to persistent or permanent sequelae. The mortality rate is up to 10% and morbidity is up to 70%. So it has phases. So phase 1, the baby will have poor suckling, hypertonia, and lethargy. So it's very important to ask about those in history. Does the baby have poor suckling? Is the baby lethargic, sleeping all the time, or hypotonic? Okay. Phase 2, there's the opposite hypertonic. There's hypertonia, increased tone, or as you can see, the oppositonis posture. Phase 3, hypertonia will start to improve. However, the baby will start to manifest with high-pitched cry, hearing and visual loss, poor feeding, and acidosis. How do we treat? Treat hyperbilirubinemia, prevent bilirubin from accumulating crossing the blood-brain barrier, good feeding and nutrition. If the patient ends up in disability, we have to do physiotherapy, for example, and sometimes we need to refer them to speech and language therapy. Thank you very much.